Assalamu alaikum, everyone. My apologies for the technical issues. I think the good thing that I'm speaking to electrophysiologists, so we are used to technical issues in the lab. So, but inshallah, I'll make it worth. I'll make it up for you. So, I think I'm the one who chose the title, but so my title is Intracardiac Echo: A Luxury or Necessity in Managing Atrial Arrhythmia. But I don't want to sound biased. I think this is probably a better title, and I'll leave it for you at the end to decide. About honestly, I think it's the utility of intracardiac echo in managing atrial arrhythmias. So I have nothing to disclose. So for my objective, because I'm an ICE user, I didn't want to sound biased. So if you don't know what to do, you ask Google. I didn't ask Google. I actually asked ChatGPT. I said, what are the advantages of using intracardiac echo for atrial arrhythmia ablation? And I think the answer that I got is probably lies around these 5 domains. And hopefully I will try to prove it to you using imaging. So I think the focus is, the 5 domains are precise anatomical visualization, detection of intracardiac abnormalities, guiding catheter placement, enhanced procedural outcome, and at the end, I'll close with radiation elimination and radiation reduction and elimination. So with precise anatomical visualization, I just want to give you a guide. I think for those who don't use ICE, I think they think of it as a very difficult thing to do. Honestly, it's pretty easy. These are the 2 ICE catheters that are available in the market. There is the one on the left is the one that we use with J&J, the AccuNav and the SoundStar. And every ICE catheter have an anterior flex, posterior flex, right and left rotation. And the one on the left, it has a locking knob. And this is the neutral position. So if all the lines are lined up, this is the neutral position. But on the left side, this is the ViewFlex by ICE. And it has, again, an anterior tilt. It's this tiny a posterior tilt, right and left tilt, and it has its own auto lock, so you don't have to lock the catheter. So, and I think this is some of my slides from ICE talks, but when we put the catheter inside the heart, the first thing that we see is the home view, and this is how the heart looks like. You can see the atrium, the tricuspid valve, the right ventricle, the RVOT, and the aorta. And this is more like a view of the ultrasound beam inside the heart. And this is exactly what we see in the home view. We see the right atrium, the aorta, the 2 cusps, the right ventricle, and the RVOT. This is our starting point when we use echo. And from here, if we want to see the interatrial septum, what we do is just a posterior tilt and then a clock. And this will take us to the interatrial septum. Oh, sorry. This will take us to a more posterior view rather than looking anteriorly. We are going a little bit more posterior, where you can see the interatrial septum, the mitral valve, the left atrium, and the pulmonary vein. And this is exactly where we can do our transeptal. And if we go more posterior, we're going to see more of the posterior aspect of the left atrium. And here, you can see this is the interatrial septum, and we can clearly see the right upper pulmonary vein. I couldn't find views of the other veins, but this is with more clock. You can actually see here, even my ablation, my grid catheter is going into the right upper pulmonary vein, and you can do that without using fluoroscopy. And then the other view, the basic view, is trying to get the catheter in the right ventricle. So we go back to the home view. What we do is a counter, and then an anterior flex, and then we just push the catheter in, and that's it. And now we are inside the RV. Because this auto locks, we just take it back to the neutral position. And this is what we see on echo. So, and once we are in the RV, we can see that we don't have any pericardial effusion. We can see full anatomy of the RV with the moderator band. And from here, the motion is just a clock rotation. And we can see structure by structure. If we clock, the first thing that we see is the interventricular septum. And if we clock more, this, like we see, so here, like we're clocking, we start seeing the left ventricle. We see here like a pericardial fat, and we can see the pap muscle. This is more for ventricular arrhythmia. This is the posteromedial pap muscle. If we clock more, we see the anterolateral pap muscle. So we can have really good view of the left ventricle, especially when we are mapping and ablating ventricular arrhythmia, which is not the focus here. And then the last thing is, this is where I think it's very useful inside the left atrium, is what we call the ridge view, where here, like we can see more of a short axis of the left atrium. We can see the appendage very clearly, the left upper vein, the aorta, the left main, and the RVOT. And the catheter would stay still here, so you can manage around the appendage and around the ridge with ease. So someone would say, yeah, the anatomy is easy. Why would they need that? Because I want to show you the utility of ICE in difficult cases. So this is a patient with very symptomatic paroxysmal AFib who was referred to us. Was during my fellowship. And like in this patient was from a center who they were like, there is a community center, they're cryo heavy, and this patient have a clear core triatriatum. So the concern was, where are they going to, when we poke, are we going to be in the lower segments, like close to the mitral valve, where we have no access to the veins, versus the upper? So the patient was referred to us. And this is what we saw on ICE. So we can see, like we are in the right atrium, this is the interatrial septum, this is our access point. And we can see, like the membrane is way below it was way below our target area. So honestly, this procedure was very smooth. This is a second case, and I don't know the answer to this. So this is another patient who was referred to us for AFib ablation. And I think this, I think this is at the time where cost was an issue. I don't know what's going on with the septum. So you can see this is the right atrium, this is the left atrium, and we see this thing in the septum that honestly we did not know what it is. So we poked, and guess what happened? We had a pericardial fusion. So we had to abort the case. The patient did very well with conservative management, and then we did further imaging. Honestly, I don't think that we had an idea what was going on with the septum, but I think the patient came back for a redo procedure, and things went okay. And this is another case where I had a patient was referred to me for ablation, and then I put the ICE catheter, and look how thick the septum is. So the septum was quite thick here, and you can barely see the rest of the left atrium. This is how thick was the septum. So we had to call our interventional colleagues to be in the room just to be prepared. But I think we were lucky. We just say, we'll try with the regular way. This is the septal stain. It's kind of scary. But the thing that we changed this time, once we had the needle through, we put the angioplasty wire through, and it went through. This gave us support to push the flat platform across the thick septum, and we did the cryoablation with no issues, and the patient did very well. So, and this is another case. So this is the home view. In the home view, we are more anterior. We should not see the septum. But you can see here that this patient have an aneurysmal septum to the point that it is bulging inside the right atrium. And the issue with, someone will say, yeah, the septum is very close to you, you can poke it. But the thing is, once we put our needle through and we put forward pressure, we can actually touch the opposite wall. And I remember we had a case like this, and we had a stain at the lateral wall of the LA with the contrast. So, that those cases, you don't want to push too much because you could go to the opposite side. So for this case, we used electrocautery for the transseptal just to minimize the forward pressure with the platform. So this is the first part about precise anatomical visualization. So, we always talk, I'm not an iPhone user, but if you want to take it a step further, like what Apple does, add a plus word to it. So if you want to think about how you can improve your anatomical visualization, so you can see what some of the vendors have. So what J&J has, so look, not only looking at the intracardiac echo, you can actually create a geometry of the left atrium just by contouring the inside, the anatomy of the heart. So when you see here, when you see the left atrium, you can contour the inner lumen, or the inner border of the left atrium, and you construct a 3D geometry of the left atrium, and you can use it to guide your map. More or less, you eliminate the pre-procedural imaging. You can do that for the left atrium itself, and you can do it for the esophagus. And this is like a nice example where they're actually contouring the left atrium, but like here, because we talked yesterday about the risk of injuring the esophagus, so you can actually precisely localize the esophagus and contour the location of the esophagus so you can stay away from it when you do the ablation. And this is what J&J even have now. They say, okay, they are trying to minimize the work that we do, so they are using AI just by sweeping the left atrium. They're using like artificial intelligence, and they will create a 3D model that is as accurate as CT. I think this is in its early stages. I think it's not like mainstream yet, but this correlated very well with CT if you want to know the precise anatomy. And also like they have also the 4D ICE, where you can do we are all used to the 3D echo. This is more of a 3D version of ICE. They call it 4D. I don't know why, but like it gives you like very well two views of the mostly for the appendage for structural procedures. So the other thing I want to talk about is detection of intracardiac abnormalities. I just want to show a few examples. So we can look at the left atrial appendage here, and we can see that there is no left atrial thrombus. This guy is a bit crazy. He goes into the PA, and I want to show you one of his examples where he actually can detect a thrombus that was missed on transesophageal echo. And you can see as he pushes it through the pulmonary artery, you can see this thrombus waiting at the os of the appendage for dislodgement, so the case was canceled. And we know that ICE is more sensitive than TEE in picking up left atrial appendage clots. The specificity is more or less the same, but ICE is more sensitive. And sometimes TEE is not an option. So this is a case of mine. This guy came in with tachycardia for a month, and this is his ejection fraction. So almost like nothing is moving. The anesthesia physician said, there is no way I'm going to give this guy anything other than I'm going to hold his hands. So you have to do the case without any sedation. So I used ICE to make sure that the patient have no clot, and the patient ended up having an arrhythmia coming from the anterior wall of the left atrium where we ablated it. So this is another case where a patient came for a redo left atrial flutter. At the beginning of the case, the patient had about 7 millimeter effusion. And I haven't ablated yet. The patient had an ablation a week ago. So I had to keep an eye on this effusion as I'm ablating. And so I have this stored so I can monitor and detect this abnormality throughout the case. Here I'm ablating across the mitral line, and at the same time I can monitor the effusion just by a short torque of the catheter. I can see the opposite side, and I can assure the safety while I deliver my lesions. This is why I give heparin for transeptal. So this is a case I was doing, and I was ready to do the transeptal. As I'm dropping the catheter, you can see there is a big thrombus on the tip of my transeptal platform, ready to go into the left atrium. And I just want to play the video again, and you can see the clot at the tip of my catheter here. And this happened to us twice, one in fellowship, one here in Saudi. So from that time, I'm giving half dose heparin, and I haven't seen this. I don't want to say that's the way, but I had to pull everything out flush. And this guy, just for the sake of time, this guy actually put the ICE catheter inside the left atrium. He works in a lab with no fluoroscopy, so he's at a totally different league. So what he does, so he monitors the tip of the catheter during ablation, and here he can see like there is a char forming at the tip of the ablation catheter. So, and he can monitor that, and what he did, he pulled it out, and there is a big char at the tip of the catheter, ready to be dislodged into the brain. So he's a big advocate of pushing the ice inside the left atrium. This is another example, so I'll just pass through it. The other thing is guiding catheter placement. So I know where my catheter is. Here it's inside the left atrial appendage. Here the catheter is going in and out of the left vein. So I know my catheter is, where is it, like real time, without using fluoroscopy. And I just want to show you, like also like in CTI, I know where my catheter is. This is the tip of the CTI. This is where I should start my ablation here. This is where the end of the ablation here. I can see all of that with intracardiac echo without using fluoroscopy. For cryoablation, you can actually use it just to see the occlusion of the cryocatheter. You can use Doppler just to see the blood flow around the cryocatheter. This is something that you can use. Enhancing procedural outcome for the transeptal, I showed yesterday. And also like with a transeptal, you can know where exactly you can poke in the septum at the posterior aspect, anterior aspect, lower high. You can gauge all of that with the use of intracardiac echo. And also, like this is another case where a patient came for a redo AFib, and his signal is actually breaking from the ridge region, which is a very tough area to keep the catheter on, because you can see here, like I'm trying to ablate on this area where his AFib is coming, but the catheter keeps slipping out of this ridge. So with the help of ice, I can look at the catheter while I'm ablating. You can see here, like after ablation, you can see here after the ablation, the whole ridge is edematous, so I know that I did the job. So, and this is how the catheter helped. With the CTI, the anatomy is very, very variable. There is a lot of recesses where people talk about steam pops and stability. So ice will be helpful. I think I got it the easy way. My CTI line was easy, but people talk about recesses. There is like a recess. There are a couple of recesses, like in some of I got some of these cases from Twitter, and those recesses, you will wedge the catheter, and you probably will have issues with steam pops. And also, like you have the RCA here, you do want to ablate next to the right coronary artery, and also like you have the prominent eustachian ridge. So probably ice is valuable around the CTI. I want to finish with radiation safety. So ice use reduces fluoroscopy time. It reduces a fluoroscopy dose. It reduces procedural time. This is in meta-analysis, so it actually shows benefit. And it did not worsen the procedural success. This is complete elimination of fluoroscopy, and the success is the same with 0 complications. I think this is probably like more of an experience center. But we always talk about the occupational risks in the cath lab. We talk about skin lesions, orthopedic problems, cataract, hypertension, and cancer. And these are the technicians, here are the nurses, and this is here like the physicians. And it is worse as you stayed longer in the lab. And people usually brush over this. But honestly, this is us, ya Jama'ah. We are at risk. And Allah subhanahu wa ta'ala will hami. But if you see, there is risk of skin cancer. The risk is 7-fold for orthopedic problems, cataract, and there is a 3-fold risk of cancer, just with the radiation exposure in the cath lab. So hopefully, hopefully I covered what ChatGPT told me. The question, is it a luxury or necessity? I'll leave it up to you to decide. Thank you.